Affect and neural activity in women with PTSD during a task of emotional interference. The incorporation of an effective symptom cluster into the diagnostic conceptualization of PTSD in the DSM-5 reflects a growing recognition that a broader range of negative emotions, in addition to fear and anxiety, are significant in the understanding of the development and course of PTSD. Self-reported negative affect has been identified as a risk factor for the development of PTSD and symptom severity. However, the relationship of positive affect to PTSD has not received the same attention in research, yet reduced positive affect has been included in the new symptom cluster for the diagnosis of PTSD. The experience of emotion is mainly subjective, and to date, the relationship between self-reported affect and patterns in neural activity have not been identified. The clinical and practical implications lie in the utility of a self-reported measure of affect that identifies disruptions to emotional processing. As such, this study aims to observe the relationship between the self-reported variable of affect and brain activation during emotionally evocative condition of the conflict task in individuals with PTSD and healthy controls. Based on previous literature, regions of interest include the prefrontal areas such as the ventral medial cortex, dorsal medial prefrontal cortex, cingulate cortex, and the limbic areas consisting of amygdala, insula, hippocampus, parahippocampus. These regions have been considered integral in the emotional processing with PTSD sufferers. Specifically, is hypothesized positive affect will be positively associated with the prefrontal regions of the brain and the reverse for the limbic areas of the brain. Negative affect is expected to demonstrate a relationship with the limbic areas of the brain, but not the prefrontal areas. Therefore, demonstrating healthy levels of affect are reflected in the top-down regulation of emotion, whereas detrimental emotional regulation is reflected in high activation of the limbic areas and low activation in the prefrontal areas of the brain. Participants included 52 women who were diagnosed with PTSD and 18 healthy controls. Inclusion criteria for the clinical sample consisted of experiencing physical or sexual assault, molestation, intimate partner violence in childhood or adulthood, and meeting the DSM-5 criteria for PTSD. All participants completed a clinical assessment including the clinician-administered PTSD scale, the structured clinical interview, and the positive and negative affect schedule expanded form, followed by a functional MRI assessment including a task of implicit emotional conflict. This task had 4 distinct conditions: attention to neutral faces, ignoring neutral faces, and the 2 conditions that are of particular interest in relation to PTSD following interpersonal trauma are attention to fearful faces, ignoring fearful faces. This task was presented while the subject was within the imaging chamber of the MRI to assess the dependent variable of regions of interest. The one-way between subjects ANOVA revealed negative affect was significantly different between the groups. Individuals with PTSD reported higher levels of negative affect than healthy controls. Individuals with PTSD reported lower levels of positive affect. When PTSD participants were oriented to fearful faces, negative affect was inversely related to activation in the left amygdala, and the positive affect was inversely related to activation in the right parahippocampal gyrus. And positive affect was inversely related to activation in the left hippocampus. In the healthy controls, positive affect was inversely related to the limbic regions in the IF and AF conditions. Both conditions in the emotional interference task demonstrated an association between positive affect and various regions of the brain. In contrast, only the PTSD group displayed significant relationship between negative affect and regions of interest. Specifically, the significant inverse relationship that was observed between negative affect and the left amygdala in the AF condition, and the relationship between negative affect and the right parahippocampal gyrus in the IF condition may indicate impaired emotional regulation, as this relationship was absent in the healthy control. The left amygdala has been linked to the processing in facial stimuli. In the presence study, increased negative affect was associated with a decrease in activation in the left amygdala. Previous studies have suggested this may be related to emotional numbing experienced by individuals with chronic negative affect. Conversely, other studies have found increased activity in the left amygdala in similar conditions to this study and is due to the enhancement of the frightening threshold. The present findings highlight the complex relationship between the activity in the left amygdala with PTS patients and negative affect. Extricating variables such as trauma type, duration of symptoms, and gender may shed light on the specific function of the left amygdala in emotional processing. Aligning with previous research, this study found negative affect was positively correlated with activation in the right parahippocampal gyrus during the IF condition. This is a region associated with PTSD symptom severity. What was unique about this study's results was activation in this area was not present in the AF condition and suggests the right parahippocampal gyrus is involved in non-conscious processing of salient distractors in PTSD. The results of the relationship between positive affect and the right amygdala in PTSD group and the AF condition in the same inverse relationship reported in the healthy control group in the IF condition reveal hyperactivation of regions of interest are associated with emotional dysfunction in individuals with PTSD. It is thought positive affect may lower the frightening threshold of neurological areas involved in sustaining affect, or reduce the interruption of the engagement of the prefrontal areas related to attention. And this downregulates the exaggerated emotional responses PTSD sufferers may have to facial expressions. The significant relationships found between negative affect and the limbic areas and positive affect and the prefrontal regions support the hypothesis of the regions of interest considered important for affective processing in PTSD, thus demonstrating healthy level of self-reported affect reflect top-down regulation of emotion, whereas unhealthy levels of self-reported affect are implicated in activation of the limbic areas. Additionally, the decreased activation in the left amygdala in response to negative faces demonstrates effective numbing with persistent negative affect, and this may be specific to interpersonal trauma PTSD sufferers. Some of the strengths. A unique objective measure of a subjective experience is provided by the MRI. Comparison to healthy controls provides an insight to the differences that relate to healthy emotional regulation. The self-reported affect may provide insight into the non-conscious emotional processing experience by interpersonal trauma survivors with PTSD, therefore informing future practice and tailoring therapy to target negative affect. The MRI experience may exacerbate negative responses. The neural substrates of affect processing and organisation in the brain are still under investigation, and it is reported PTSD has a broad range of effects on brain function and not just the ones under investigation. The results of this study may not generalise to males or individuals who have been exposed to other types of trauma. Additionally, negative affect experienced by this type of trauma is more closely related to anger and shame rather than just fear. Therefore, it is considered the negative affect activation in regions of interest are specific to PTSD as a result of interpersonal violence. While the utilisation of the PANIS, a reliable measure of negative and positive affect, generalisability of this research is limited to the scope of this measure. Additionally, heterogeneity of the race was not replicated in the healthy control group. The observed relationships of reduced positive affect in the activation in the hippocampus and amygdala in the presence of overt and obscure threatening facial stimuli have important clinical implications in the possible implementation of therapeutic interventions aimed to increase positive affect with interpersonal trauma PTSD sufferers. Clinicians may be directed to look out for self-reported negative affect, as this has been associated with emotional numbing and reflected in reduced reactivity in the amygdala. Therefore, within this clinical sample, psychologists may highlight interventions that increase emotional awareness through strategies designed to enhance emotional regulation and distress tolerance. Additionally, this study also identified overt and peripheral facial expressions which may represent discrete trauma triggers. Future research should be directed to examine other variants of trauma exposure to establish a relationship with affect. Thank you very much.